Now, which is the most dangerous type of ectopic pregnancy? This is my question number 2. Is it interstitial, ischemic, ovarian or cervical? This type of question has also been asked in one of the FMG exam. It is not that previous questions of the exam only those part is discussing. No, I am telling you additional points as well on which the exam, there may be some expected questions which can come. Okay, so the most dangerous part or type of ectopic pregnancy is interstitial. Now, what do you understand by interstitial ectopic pregnancy? Interstitial ectopic pregnancy is pregnancy growing somewhere here. So, this type of ectopic pregnancy can continue here and it can take some part of the uterus. So, before it ruptures, it can continue here. So, this pregnancy may likely to be get missed as a uterine pregnancy, normal intrauterine pregnancy. Okay, and this part is again a vascular part of the uterus and the fallopian tube. So when it ruptures, it is causing a dangerous type of ectopic pregnancy. Also, just remember, if there is an ovarian ectopic pregnancy, what is the criteria for ovarian ectopic pregnancy? It is Spiegel-Berg criteria. If it is cervical ectopic pregnancy, the criteria is Rubin's criteria. If it is primary abdominal ectopic pregnancy, then the criteria is study Ford. And also remember, what are the points where medical treatment has to be given for unruptured ectopic pregnancy? You should revise that particular part also. Now, what is a drug for giving a medical treatment for unruptured ectopic pregnancy is methotrexate, and you should revise the criteria for the methotrexate. Next, question number 3. A 25-year-old primigravida normotensive comes at 24 weeks of pregnancy for 24 weeks of pregnancy for antenatal checkup. Now her blood pressure is 150 by 92 millimeters of mercury, but urine proteins by dipstick method is negative. What is your most probable diagnosis in this case? Okay, so blood pressure has been raised during pregnancy and the first recording is at 24 weeks because it is written in the question she was normotensive before that. Okay, so it is a case of pregnancy induced hypertension, that because of pregnancy she has become hypertensive. So similar pattern of question has already been asked in previous FMG exam. Okay, so just to give you a clue, pregnancy induced hypertension or preeclampsia is very important topic for your upcoming FMG exam. Why it is important? Because incidence of preeclampsia in Indian females during pregnancy is around 10%, which is quite a high number, and most of the time when you are working in the clinicals you find such patients. So you should be, as a doctor, you should be able to diagnose and manage these cases perfectly. Okay, that is what is an idea of asking questions in your FMG exam. So what is your most probable diagnosis in this case? Preeclampsia, gestational hypertension, chronic hypertension, or chronic hypertension superimposed by preeclamptic changes. Since there is no proteinuria by the dipstick method, so this is a category of gestational hypertension where proteinuria is absent. And one more important point you should remember is blood pressure in these cases should be rising after 20 weeks. So when it is a preeclampsia, apart from blood pressure, there is proteinuria added. To differentiate between mild preeclampsia and severe preeclampsia, proteinuria has got no significance. It is that end organ damage. If present, it is a severe preeclampsia. If end organ damage symptoms and signs are absent, it is mild preeclampsia. Okay. So only blood pressure is raised and this is occurring after 20 weeks of pregnancy. Chronic hypertension is blood pressure present in less than 20 weeks of pregnancy, and chronic hypertension superimposed by preeclamptic changes means blood pressure is present in less than 20 weeks of pregnancy. That means it is a case of chronic hypertension and now proteinuria is being added or it is superimposed by preeclamptic changes. So friends, pregnancy-induced hypertension or preeclampsia is very, very important points. Plus, you should remember the HELP syndrome as well, because they are asking questions on HELP syndrome, and they give you a clinical question where they can write the lab investigation finding as well, and you should be able to mark the correct answer. Okay, so HELP syndrome you already know is hemolysis, elevated liver enzymes, and low platelets. So that is what is the diagnosis of HELP syndrome. HELP syndrome is a complication that is seen in severe preeclampsia patients. Okay. Then you should know another important question, that is, which of the following is not used in preeclampsia? So similar question has already been asked in one of the FMGE exam. Okay, so options given to me are methyl dopa, atenolol, labetalol, or hydralazine. So atenolol is not being preferred in cases of preeclampsia. So the preferred drug is labetalol, which is our first line drug for hypertension occurring in pregnancy. This is very useful when there is acutely raised blood pressure. It's also a wonderful drug in cases of hypertensive crisis occurring in pregnancy. It's also been used for chronic hypertension in pregnancy. So the safe antihypertensives that are used in pregnancy includes labetalol, it includes nifedipine, and number 3, that includes hydralazine and even alpha methyl dopa. The only drawback with alpha methyl dopa is that onset of action is very much delayed, but comparatively all these drugs are the safe antihypertensives, and if it can be given to the chronic hypertensive patients who are pregnant, then again it does not cause any teratogenic effect. One more thing, if the blood pressure is very raised and patient has come up with hypertensive crisis, you have started with labetalol IV. Advantage with labetalol is it can be given IV or it can be given oral. Both ways it can be given. And if it is hypertensive crisis, blood pressure is very high, for example 180 by 120 or more, then you start with IV labetalol, and every 10 minutes you can increase the dose to maximum 220 milligram like per hour. Okay, and you can add on nifedipine, but remember, nifedipine should not be given by sublingual route. It is to be given oral with a sip of water. Okay, if still blood pressure is very high, again you have to start with magnesium sulfate in cases of severe preeclampsia where there is warning symptoms present like headache, blurring of vision, etc., because your patient might throw fits. Okay, so remember, when it is a severe preeclampsia with impending signs of eclampsia like headache, blurring of vision, epigastric pain, etc., then do not forget to start the anticonvulsant as a prophylactic measure. Okay, if the blood pressure is not getting control on the antihypertensive you have started, so you can add on nitroglycerin drip. Fine. Now, which antihypertensive is contraindicated in pregnancy? You know, it is ACE inhibitors like enalapril, lisinopril, etc. Why they are contraindicated? Because they cause teratogenic effect. If it is given in the first trimester, it causes teratogenic effect. If it is given in the second or third trimester, it causes placental insufficiency or hypoxia, chronic hypoxia.